Assalamu alaikum everybody, my name is Faisal Alfroukh and today we'll be discussing the histology of the respiratory tract, which is 1 and 2, okay? I'll be covering inshallah all the concepts for you guys, and if you guys have any questions, don't hesitate to contact me through my number or my email, whatever suits you. We're gonna start with the structural organization of the respiratory tract, okay? We're gonna be now firstly discussing what the upper respiratory tract, okay? It consists of 3 parts: nasal cavity, paranasal sinuses, and pharynx, okay? And it's very important to know that the upper respiratory tract, it develops embryologically from the primitive oral cavity, okay? This is very important to know. And we will be discussing the lower respiratory tract later in this video. Okay, so we have 2 portions to discuss. We have the conducting portion and the respiratory portion. It's very easy. Basically, the conducting portion is has the nasal cavities, and it has the pharynx and larynx, trachea, bronchi, bronchioles, terminal bronchioles. And what does it function as? It basically just cleans and humidifies air and provides like a pathway for air movement, okay? While the respiratory portion, it consists of only the respiratory bronchioles, alveolar duct, and alveoli, and it's just responsible for gas exchange. Now, for the conducting portion, as you guys can see, here is the trachea, primary bronchus, because there is the bifurcation of the trachea, okay? And then it divides into secondary, and then as we progressively keep on dividing, we get into terminally bronchial and the respiratory bronchial. And respiratory bronchial is part of the respiratory portion from its name. And of course, it includes the alveolar duct and alveolar sac. What is nasal cavities? It's just basically paired chambers that is separated by a bony cartilaginous nasal septum. There's 3 regions that are very important for the nasal cavities. The first region is the nasal vestibule, okay? The second region is the respiratory, and the third one is the olfactory. We will be discussing them in details. The first one is the vestibule of the nasal cavity. It's basically just the front part of the nasal cavity, just inside the nostrils, okay? It is lined by a stratified squamous epithelium with hair, sweat, and sebaceous glands. And then, posteriorly, it will become thinner and changes to what? It will become pseudostratified columnar epithelium. And what does this vestibule of nasal cavity do? It just basically traps dust and protects the airway, okay? The respiratory region. As we said, as we get more inside, it will become pseudostratified, ciliated columnar epithelium, and this is in the respiratory region of the nasal cavity. We have goblet cells in the respiratory region, and what does this goblet cell do? It basically secretes mucus to trap what? Dust. Okay? Conditioning. Brush cells have short microvilli. It's important to know that it has short microvilli, and it can act as a sensor, okay? The small granule, or whatever this name is, it's basically just secreting the hormones, okay? Secreting the DNES, okay? The basal cells, stem cells that replace other cell types, okay? I have a really nice mnemonic for you guys for this one. I'll just tell you it after I finish this slide. Lamina propria, it's basically just a loose CT, which is rich in capillaries and venous plexuses. Tamam? And what does this lamina propria do? Warms air, okay? And humidifies and filters it, okay? Humidifies it to the saturation of the body temperature, of the body level. And what's the function? As we said, conditioning air, warms, moistens, and filters inhaled air, and defense. And how does it defend? By immune cells like lymphocytes, macrophages, and mast cells. As you guys can see, we have this nice mnemonic. Good boys share what? They share big lungs. Big lungs. Like, okay, what is mucus? As we said, mucus is goblet cells. Oh, I'm sorry. Goblet cells. Wait 1 second. Goblet cells, okay? Senses. The sensory is what? Remember, على طول, brush cells. And hormones, على طول, Kolchitsky, okay? I just want to call it that because it sounds fancier. And renewal was what? The basal cells. Protection, lamina propria. Moving on to the olfactory region of the nasal cavity. Where is it located? It's just located it's in the upper 1/3 of the nasal cavity, okay? And what does it do? It detects the smell, okay? Its epithelium, it's specialized olfactory mucosa. There's no goblet cells in olfactory region, okay? What is olfactory receptor cells? It's basically bipolar neurons with immotile cilia. What does these bipolar neurons do? It senses the odor molecules and sends signal to the central nervous system. Okay, what does the supporting cells do in the olfactory region? It's the most numerous, and they provide support and secrete odorant binding proteins. Tamam? They are the most common in the olfactory region. Tamam? We have also basal cells, like the respiratory region. They are stem cells for receptor and supporting cells, as we said, like before. Similar function. Brush cells, they are basically sensory cells. Again, same thing with microvilli, like the respiratory region. The lamina propria, it's a CT with blood and lymphs, tamam? And they are unmyelinated olfactory nerves. You should know this. This is important, okay? And Bowman's gland. Okay, what is Bowman's gland? Oh my God, I never heard this before. Listen, okay, so Bowman's gland are very easy. They're just there. Why? Because they want to secrete watery fluid. Why? To dissolve the odor and refresh the surface. Because without it, there will be a big problem for the smell. You wouldn't be smelling properly. And will I leave you with mnemonic? No, I'll give you this one. This is only small brain, small? No, only smart brains breathe. OSBB. O is what? Olfactory receptor cells. S, supporting cells. B, basal cells. And B, the other B, brush cells. Tamam? We have, moving on now to the paranasal sinuses, okay? What's its definition? Basically, the paranasal sinuses, they are paired sinuses, and they are air-filled in skull bones. Look, I'll get into details here. And the types we have are the frontal, ethmoidal, sphenoidal, and maxillary, okay? Tamam. How do they connect? They open to the nasal cavity through small openings, tamam? And their lining is the respiratory epithelium with thin lamina and propria and few mucus glands. And it's very important to know that they drain mucus into the nasal cavity, okay? It's very important to know. And what does it function as? It's basically just to lighten the skull weight, tamam, and add resonance to the voice. And what does it also do? It helps with the other regions with the mucus, and helps. Again, I'm sorry. Let's start with the functions again. It lightens the skull weight, adds resonance to the voice, and the mucus in it helps moisten and clean nasal cavity surfaces. Because when we breathe air, it will be either humidified, dehumidified. It's either like too cold, too hot to endure. So it will be regulated here. Tamam? Let's go here. As you guys can see, just between your eyebrows, we have the frontal sinus. Where? Because it's in the frontal area, as you guys can see here. Okay? We have the ethmoid surface. It's just between your eyes. Okay? Tamam? And the nasal cavity just between your nose. Okay? Wait, no, I'm sorry. The nasal cavity is inside your nose, and the maxillary sinuses is just between your nose, just posteriorly. But if you want to go in this orientation, the frontal sinus, as you can see, it's in the frontal. The ethmoid is just between the frontal and the sphenoid, and the sphenoid is just behind the maxillary sinus. And as you guys can see, we have the pharynx here. Okay, epiglottis. This should be removed anyways. Epiglottis, it's basically a flat lap just above the larynx. And what does it do? It prevents food from entering the airway. Without it, the food would enter your airway, and khalas, bye-bye, you're done. What's the surfaces of it? We have two. We have the lingual and laryngeal. What does the lingual do? It's just for, from its name, lingual, to speak. Tamam? And laryngeal, and for the lingual, it's also covered by stratified squamous epithelium. And laryngeal, it's just starting as stratified squamous and then transitions to pseudostratified ciliated columnar epithelium. And the glands of it has a mixed mucoserous glands just beneath what the epithelium for what lubrication. Okay, this is a mnemonic. Lingual is squamous, laryngeal shifts, because as we know, lingual is just always squamous, but laryngeal transitions and becomes what? Pseudostratified. Okay, so this is just in the photo. As you guys can see, this is what the lingual surface. It's stratified squamous epithelium, just like that. This is the seromucous acini. And we have also here the transition zone where the stratified squamous epithelium becomes pseudostratified epithelium. This is a respiratory. As you guys can see, there's a shift and transition in the structure. The vocal cords. Vocal cords, basically, we have two types. We have the false and the true vocal cords. Tamam? The false vocal cords are basically immobile and they are lined by respiratory epithelium, okay? And of course, they contain seromucous glands. The true vocal cords, they are mobile, unlike what the false vocal cords. And they are responsible for sound production. As you guys can speak, when I'm speaking right now, I'm using my true vocal cords. Tamam? It's covered by what? Non-keratinized stratified squamous epithelium. Why? Because the non-keratinized stratified squamous epithelium, it resists friction. Okay? And what does these contain? Okay, it contains lamina propria, which is the superficial layer, and vocal ligament, which is a dense elastic connective tissue, and vocalis muscle, which is striated muscle, okay, that controls tension and pitch. The trachea, okay, the trachea, as we know, it's 2.5 centimeters in diameter, and it's very short. It's a flexible cube. It is 10 to 12 centimeters long, and it's connecting larynx to bronchi. And okay, what's its function? It's basically just conducts air and helps warm, moisten, and filter it. How? We'll get into it. It's, as we said, how to identify it in a really nice way. C-shaped cartilaginous rings. Tamam? We have mucosa as one of its layers, and lamina propria. Mucosa is basically, as we said, ciliated pseudostratified columnar epithelium, and it has a thick basement membrane, tamam? And of course with collagen fibers. Lamina propria, on the other hand, it's a loose connective tissue with elastic collagen fibers, immune cells, and lymphatic tissue like buds. Clinical significance, okay? Clinical significance is, we're gonna start with inflammations, rhinitis, sinusitis, pharyngitis, adenoiditis, all the itis, okay? Rhinitis is important. And what is rhinitis? Rhinitis is basically swelling of mucosa due to engorged vascular lamina propria, causing nasal blockage and difficulty breathing. COVID-19 is a good example of it, causing what? Loss of smell, and how? By damaging the supporting cells. Usually, it takes 10 days to recover from it. Okay, singer's nodule, when you sing, a lot of singers, like Taylor Swift or whoever you guys listen to, it's basically a polyp in stratified squamous epithelium of the true vocal cords, and this is abnormal. Why? Because it leads to hoarseness or voice changes, okay? Because, like a smoker, you'll find that his voice is very hoarse. Just imagine his voice, and that's hoarseness. Now, checkpoint. I need you guys to stop this video and answer this question, please. Okay, so the change from stratified squamous epithelium to pseudostratified columnar occurs where? Nasal septum? Hell no. External nares? Hell no. Inferior meatus? No. The answer is posterior vestibule. Okay, I'll let you guys do this question and then I'll solve it for you guys. The nasal vestibule is primarily lined by what? It is lined by stratified squamous epithelium with what? Hairs and glands. Okay, let's go back and I'll show you. أيوه. See, stratified squamous epithelium with hairs, sweat, and sebaceous glands. Okay. Anyways, okay. So the lamina propria in the respiratory region contains what? I'll leave this question for you guys. Okay, so the lamina propria in the respiratory region contains venous plexuses and serum mucus glands. Okay, I told you this is very important. هلا, which cell can sense mechanical stimuli? على طول. The answer is gonna be goblet cells, no. Basal cells, no. Ciliated, no. Brush cells. Last question, I think. Which of the following is absent in olfactory mucosa? If you said olfactory receptor cells, you are wrong. If you said basal cells, you're wrong. Brush cells, you're wrong. The answer is goblet cells. Okay. Now we're gonna start with the respiratory tract 2. Okay? هلا, just give you a little orientation about the lung, you know. Lung is basically just a filled or air-filled organ, تمام, and it's located on both sides of the chest. Okay, they are covered by what? They are covered by pleura, which is what? A thin tissue layer. تمام. We have lobes. Okay, look, and here you can see the lobes here and here and here. This is the oblique fissure. عفوا معلش. They are separated by these fissures, but this is 1, 2, 3. This is 1 and 2. Okay, in the right lung we have the upper lobe and we have the middle lobe and lower lobe, and they are separated by the oblique fissure and the horizontal or transverse fissure. Okay, on the other hand, the left lung, تمام, it is divided by the oblique fissure. Okay, we have also bronchopulmonary segment. We have 8 on the left and 10 on the right. I know there's a lot of opinions on this, but just stick with what I tell you, and inshallah you'll be fine. And we have also pulmonary lobules, which is here, the same ones as I told you. Anyways, bronchial tree in a nutshell. Okay, because it's a very heavy concept in the lecture. Okay, the trachea divides into 2 primary bronchi. Okay, this is one and the other one will be here. Tamam? It divides into left and right main bronchi or primary bronchi. Okay, each primary bronchi enters what? The lung hilum. Okay, and the right lung divides into 3 secondary, or if you want to call it lobar bronchi, and 1 for each lobe. Okay, 1 lobar bronchi for each lobe, while on the other hand, left lung divides into 2 secondary bronchi and again 1 for each lobe. Tamam? Each secondary bronchus gives away segmental bronchi. It divides into what? Segmental bronchi. While and of course they are supplying what? The bronchopulmonary segments. These segments further divide into what? They divide more. Tamam? They divide into what? They divide into terminal. They divide first, these segments first they divide into bronchioles, then they divide into terminal bronchioles, and then to respiratory bronchioles. And eventually from the respiratory bronchioles, you'll be getting alveoli. What is alveoli again? Site of gas exchange. And of course, I'll not leave you guys with no mnemonic for this one. I'm sorry. People say to breathe right. You have to breathe right with what? Primary bronchi, secondary bronchi, tertiary bronchi, bronchioles, respiratory bronchioles, eventually alveoli. تمام؟ هلا moving on. This is what? This is a bronchiole. Okay, this is bronchi. Why? How do we know? Hyaline cartilage. Right away, it's a giveaway. هلا. It starts similar to trachea in structure. It's similar, but trachea is a C-shaped cartilaginous. Okay, and when bronchi enters lung, tamam, the wall changes. The wall becomes altered, not altered in a negative way, but it changes. Cartilage links, they are replaced by irregular. It becomes segments. Cartilage plate around the wall, okay? And smooth muscles appear. We will be having a considerable amount of smooth muscles, تمام? And this smooth muscle, they form what? They form a complete circular layer, as you guys can see. This is formed thanks to the what? Smooth muscle. تمام؟ هلا intrapulmonary bronchi. Very long name, صح? Easy. It has only 5 layers, okay? Focus on this one. It only has what? 5 layers. What are these layers? We have the mucosa. على طول. Mucosa. What is mucosa? Okay. It's a ciliated pseudo-stratified epithelium. And why is it folded? It's folded due to the smooth muscle contraction. As we said, smooth muscle is responsible for the what does it do? It's responsible for forming a complete circular layer. Anyways, lamina propria, it's a loose connective tissue with elastic fibers and bolt. Okay, bolt is what? Bronchus associated lymphatic tissue, if you want to know its name. But knowing it as bolt is enough. Muscularis is continuous smooth muscle layer. And what does muscularis do? It regulates the airway diameter by contracting or dilating. Smooth submucosa, it's a loose connective tissue. Again, we have it as a loose connective tissue with what? Glands, especially in larger bronchi. It might disappear in small bronchi. I'll get to this. Cartilage layer also, we have a cartilage layer. What is this cartilage layer? We have, which is the irregular hyaline plates, okay? And they shrink as bronchi, they get smaller, okay? How? Because bronchi, when they get smaller, خلاص, eventually they will be dividing into bronchioles. And we know in bronchioles we have no cartilage. We'll get there. And of course the external part, the tissue, we cannot forget about it. It's a dense connective tissue connecting bronchi to nearby tissues. Hey, bronchioles, حبيب الجماهير. Bronchioles, basically, small airway, okay? It's basically airway conduction, okay? And bronchioles has no cartilage. Never that it has cartilage or what? And glands, no glands. In large, but we have an exception. We also, sometimes, like very rare, we would have in large bronchioles, we would have very, very little cartilage, but we don't even take it into account. Okay? Anyways, large bronchioles, they divide into terminal bronchioles, تمام? Which then form respiratory bronchioles. تمام? The layers of the bronchioles. تمام? We have mucosa, muscularis, and adventitia. As we said, the bronchi is the intrapulmonary bronchi is what? 5 layers, unlike the bronchioles, 3 layers. Anyways, the mucosa, ciliated epithelium with loose connective tissue. And this loose connective tissue is lamina propria. And mucosa is very, very rich in what? Elastic fibers. Muscularis, it's a thick, smooth muscle layer. And what does it control? It controls the airways diameter as the bronchi, same function. Adventitia, connective tissue connecting to surrounding alveoli, and may what? It can have lymphocytes. عادي. Okay. We're gonna get into the epithelium part. Anyways, larger bronchioles, as we said, ciliated pseudostratified columnar epithelium with few goblet cells. Smaller bronchioles, what? Simple ciliated columnar, or what? Cuboidal. It can be either columnar or cuboidal epithelium. Goblet cells disappear toward terminal bronchioles. تمام? They are gone. خلاص, bye. What is Clara cells or club cells? Both names works. They are where are they found? They are found in small and terminal bronchioles only. Please know this. And they increase in number distally. They keep on increasing. Well, the more the division, the more they increase in number. They also have bronchioles. Also, they contain brush cells and small granule cells. As we said, neuroendocrine. We talked about it. And Clara cells. What is it? It's non-ciliated, never. And it's a dome shape. And it secretes proteins. It's protein secreting cells. Okay, what does the club clara or clara cells do? Its function? Secrete surface active agent, prevents airway collapse. So when we secrete surface active agent, على طول prevents airway collapse, alhamdulillah, and also secretes this protein, CC16 protein, and when we secrete it, anti-inflammatory and immune modulating is occurring, okay? It prevents that from happening. And they act as progenitor cells. Why they do that? They basically just replace other epithelial cells. Progenitor cells replace other epithelial cells. Moving on to the lower respiratory tract, okay? We're gonna get into a lot of details now. Larynx basically is one part, trachea, bronchi and divisions, we already spoke about them, and lung, we spoke about it. Just know though that they develop from the foregut endothelium and its surrounding mesenchyme. Okay? Respiratory bronchioles, we're gonna get into its details. Excuse me. Okay? They act as a transitional zone. And what do they do basically? What do they get involved in? They are involved in both air conduction and gas exchange. Okay? What is its wall composition? Just get into details. Faisal, yalla. Okay? Small cuboidal epithelium with ciliated cells and club clara cells. Okay? Club cells, they dominate distally, just away. Okay? Rest on lamina propria with elastic fibers and smooth muscle. They rest on where? Lamina propria, and this lamina propria doesn't have it. It has next with elastic fibers and smooth muscle على طول. And of course scattered alveoli, which is thin out pouching for gas exchange. As you guys can see, this is alveoli, smooth muscle, connective tissue. This is the epithelium, as you guys can see. What did we say about the epithelium? Please comment down below. And of course, smooth muscle. See, we don't have hiding cartilage, which indicates that it is bronchioles rather than bronchi. Will I leave you with this word? I said it a lot, okay? It's this thing of the day, of this concept, cool, calm, clara, protects airways. Consider this a girl, she's very cool, she's calm, and it protects the airways. She's just the hero of the day. Tamam? Cilia is gone. We can indicate from this sentence that cilia is gone. Khalas, bye-bye. So it means that it's non-ciliated, as I told you. And club cells secretory protein, it secretes this protein, which is CC16, and it prevents collapsing by what? The surface active agent and progenitor function. Tamam? Of course, anti-inflammatory. Okay, moving on to the alveolar duct and alveolar sac. Tamam? I just wanted to look in a nutshell. I'll give it to you guys. When you see a long line or long space, this is على طول alveolar duct. Okay? When you see it sac-like or pouches, alveolar sac, right away, don't even hesitate. Okay? Just let's have a quick look. Alveolar ducts, as we said, long passages with almost no walls, only alveoli form their boundary. Tamam? As you guys can see, the alveoli is forming the boundaries of the alveolar duct. Okay? And they contain what? Smooth muscle rings in the interalveolar septa. While on the other hand, alveolar sacs, it's basically spaces surrounded by clusters of alveoli that open into them and found mainly at the end of the alveolar duct, but may appear along the length. What does this mean? What does this sentence mean? Found mainly at the end of the alveolar duct, but may appear along the length. Look, this is the end of the alveolar duct. So we'll be having here alveolar sac. This just makes sense because This just transmits everything we need from here to the alveolar sac, gas exchange. يعطيك العافية. Alveoli. As we said, terminal airspace is of the lung. تمام. It's just there for airspace and gas exchange. Main site of gas exchange على طول between air and blood. And each lung has 100 to 150 million alveoli. You don't need to know this. And the structure of it is thin-walled, okay, and polyhedral sacs. It's 0.2 millimeter in diameter. Imagine how thin they are. And of course, the alveoli is surrounded by capillaries, which is making sense because capillaries also is responsible for gas exchange. And capillaries, what do? Gas exchange. Bring blood very close to the inhaled air for efficient exchange. Anyways, okay, alveolar epithelium. Okay, the alveolar epithelium, we have two types على طول. Type 1 pneumocytes and type 2 pneumocytes or septal cells. Type 2 alveolar cytes, whatever you want to call it works. Just make sure it's one of these. Yani. Don't create your own name. Type 1 alveolar cell is just flat, okay? It's flat, thin, squamous, and it covers 95% of the alveolar surface. It's very major, okay? And only 40% of total alveolar cells has it. Tamam? How is it joined together? Occluding junctions. Why? Because it prevents leakage. Keep this in your mind, please. And of course, there is no cell division. And what's the function of it? Gas exchange. Gas exchange. And part of the air-blood barrier. تمام? Type 2 alveolar cells. تمام? Or type 2 pneumocytes, whatever you want to call it. It's cuboidal, unlike the type 1 alveolar cell. It's flat thin. This one is cuboidal. Cuboidal secretory cells, often at septal junctions. 60% of alveolar cells, but cover only 5% of the surface. See how they are different? Because each one has their own size, their own orientation, their own everything. تمام? And type 2, basically, they have laminar bodies, aka granules. What's the function? As also even Dr. Shams mentioned it, but I'll say it again. They secrete surfactants. تمام? And what does surfactant do? It basically just reduces surface tension and prevents collapse. Okay, because if you have no surface tension, we will have an increase in surface. If we have a deficiency in surfactant, we will have an increase in surface tension, and of course, the lung will collapse. And another function of it, progenitor cells for both type 1 and type 2. تمام? They act as what? Progenitor cells. Just that simple. It's that simple. And will I leave you with no mnemonic? No. Type 1 inhale, type 2 inflate. In a nutshell, just like that. It's just that simple. Type 1 gas exchange. Type 2 inflates alveoli by producing what? Surfactant, which what? Reduces surface tension and regenerating cells. Surfactants. What is surfactant? It is secreted or produced by type 2 pneumocytes, and they are stored in lamellar bodies. And I have a question for you guys. What does exocytosis relate to it? If you know, please either message me the answer or comment it down below. It is composed of phospholipids, okay? And mainly, I don't know, I forgot this one, I'm sorry. But just know it like that. And neutral lipids and proteins. What is DPPC? I forgot it, but I already have you guys covered. It's a main component responsible for reducing surface tension. Okay? Okay. Its functions: decreases alveolar surface tension. And by decreasing surface tension, of course, that will prevent collapse. And another function, aids clearance of foreign materials. Of course, there's macrophages. It just makes sense. A clinical note you guys have to keep in mind. See, I hope you guys didn't see the answer, but it is secreted via or by exocytosis to coat alveoli. And I'm sorry, it's if we have deficiency alveolar collapse. This is its name. And yeah, of course, deficiency or insufficiency of it, we find it mainly in infants. And because they lack surfactant, developing neonatal respiratory distress syndrome. Macrophages, they are derived from blood monocytes, and they are part of the mononuclear phagocyte system. Okay? And the functions of these are, they function within alveolar air spaces, and they remove dust, pollen, and RBCs. Okay? RBCs, by RBCs, I mean like the in functioning ones, okay? Tamam? Moving up the bronchial tree in mucus and cleared by swallowing or coughing, okay? So as I told you, macrophages plays a very vital role in surfactants. Okay, septal. I was talking to you guys about the alveolar. Please don't confuse these two, okay? Alveolar function with air spaces and removes dust, pollen, and RBCs, which in turn will be having a removal of the dust cells and heart failure cells. And the move up of the bronchial tree in mucus basically just clears by swallowing or coughing. على طول. Septal macrophages, just keep this in mind, they are found in connective tissue of the interalveolar septa, okay? And they have phagocytosed debris. Makes sense because macrophages. And may stay long-term in septa. Both types increase in smokers. Tamam? Because macrophages is like needed more in smokers. I mean, like, it just makes sense. Interalveolar septum. Okay? Thin connective tissue between what? It's a thin connective tissue between adjacent alveolar spaces. As you can see, they are adjacent here. Okay? And what does it contain? It contains elastic and reticular fibers. I'm sorry, guys, just there's a lot of people coming in and out, so let's repeat this slide. Okay, so as we said, interalveolar septum, it's a thin connective tissue. Between what? Between adjacent alveolar air spaces. Very simple, صح? And what does it contain? It has elastic and reticular fibers. And what do these do or allow? They basically allow stretching and recoiling during respiration. And they are very, very rich in capillary network. From where? Pulmonary artery. على طول. What does the capillary again do? Site of air-blood barrier. And alveolar pores, which is of Kohn. I'll get into this. It's connecting neighboring alveoli that open into different bronchioles, allowing air circulation between them, as you guys can see. If we have this alveolar sac closed, tamam, this thing would allow us to go for another alveolar compensating this alveoli. Okay? I hope it makes sense. Air-blood barrier, it's a thin portion. Okay, and it's a site for most gas exchange. It's a thin layer of surfactant, type 1 epithelial cells and its basal lamina, capillary endothelial cells and its basal lamina again. And this is basically what it contains. The two basal laminae are often what? Fused. They are fused together. Okay, and the thick portion we were talking about, of course, the thin portion. We finished it now. Moving on to the thick portion, it contains CET cells like macrophages and fibroblasts. And as we said, macrophages, what do? They are, depends, alveolar, they function with alveolar spaces. Septal, they are phagocytosed debris and they stay long-term in septa. It's very simple. And fibers between two basal lamina, okay? As you guys can see from here, this is the basement membrane, and this just shows the alveoli and the air-blood barrier, how do they exchange the CO2 with the O2 to the blood, so deoxygenated. Very simple. And function allows tissue fluid accumulation before lymphatic drainage, because if you have lymphatic drainage before, often after fluid accumulation, allows tissue. If we have fluid tissue after lymphatic drainage, we'll have a really big problem. So always remember, air-blood barrier allows tissue fluid accumulation before lymphatic drainage. Okay, so again, I'm sorry. Air-blood barrier, we'll continue it. Serous membrane. It's a serous membrane. And what does it cover? It covers the lung and thoracic cavity wall. تمام? The parietal pleura is part of it. Visceral pleura, also there. Parietal pleura, it lines internal thoracic cavities. Visceral covers the outer lung surface. As you know, we have fibrous, then parietal, visceral, and we have here what? The air, blood, we have the lung, sorry. And of course, in the lung, we will have the air-blood barrier there. Layers are continuous at the hilum. Just remember, it doesn't stop there. It's always continuous at the hilum. And both pleurae consist of simple squamous mesothelial cells on thin connective tissue with what? Collagen and elastic fibers. And what do we need these for? Flexibility and elasticity during breathing, because we don't want a stiff lung, you know. Pleural cavity, narrow space between layers. And what is it lined by? Mesothelium. Mesothelial cells. What do they produce? Serous fluid. Why? So it can lubricate surfaces for smooth movement. I will leave you with this nice mnemonic. Very polite pair sliding smoothly. Visceral pleura and parietal pleura sliding smoothly thanks to slippery serous fluid. Clinical significance. We have the bronchial asthma, tamam, and emphysema and cystic fibrosis. These are very important. They might come in the exam. Bronchial asthma, tamam, chronic inflammatory disease of airways, and they are genetic and environmental. They can be either or, okay? Features of it, we have an increase in goblet cells, which is what? A thick basement membrane, and hyperplastic smooth muscle layer, and the symptoms of it: wheezing, coughing, shortness of breath, and chest tightness, okay? Emphysema, I think we took it in physiology of the pulmonary. Chronic lung disease, mainly due to cigarette smoking, and dilation and permanent enlargement of what? The air spaces, with what? Destruction of alveolar walls. Main symptom, gradual shortness of breath. You gradually just feel, oh my god, I cannot breathe properly. So that would indicate emphysema, especially if you're a smoker, so quit smoking. Cystic fibrosis, it's a genetic disorder, okay? It's a thick, viscous mucus from where? From exocrine glands. And what does it cause? It causes a malfunction of mucociliary escalator, and it basically accumulating very thick mucus. And as we know from mole, you don't know that, you don't need to know, but just connect it with the F450, okay? And it leads to frequent respiratory infections. Okay. Irregular, okay. So this is checkpoints. I will leave you guys to it. Please answer this question. In intrapulmonary bronchi, cartilage rings are replaced by what? They are replaced by what? Please answer this question. Stop the video and let me know. Okay, so the answer is gonna be, of course, not fibroelastic lamina. Of course, not bone spicules. Didn't even speak about it. And of course, not smooth muscle. So it just makes sense. Irregular cartilage plates. Okay, which feature distinguishes bronchioles from bronchi? Please answer this question. Stop the video and answer it, please. The answer is gonna be easy: absence of glands and cartilage. Okay, very simple. And the main histologic change in emphysema is gonna be what? It's gonna be destruction of alveolar walls and dilation of spaces. Okay? Last question, I think, yeah. Last question is gonna be, in cystic fibrosis, the main defect causes, we literally just spoke about it. You know what, I'll go back even for you guys. Yalla. The answer is gonna be C. Thank you guys. And I hope you guys understood it all. If you guys have any questions, please don't hesitate to let me know, and wish you great studying.